Thank you, sir, for the opportunity. So, there is some loose connection. So, I'll be talking about my personal experience with the EMV lenses from Raynor. For no financial interest for this particular talk. So, as we all know that natural crystalline lens has got good accommodation, clear vision at all distance, clear vision in all lighting condition with a greater contrast sensitivity with no rotational asymmetry. So, however, the aging and also dysfunctional lens does not compensate for the corneal aberration. But the one good news is the newer IOLs has shown admirable ambition in overcoming this. Can you able to get me the connector from other hall, please? So this is about the evolution of the monofocal IOL. We started with PMMA, then we have gone to do the silicon, then acrylic. In acrylic, both hydrophilic and hydrophobic. Then comes the square edge, then comes the aspheric IOL. So what should be the ideal monofocal intraocular lens? It should give a very clear optical quality, uncompromised vision for distance. It should compensate for the spherical aberration on the cornea, easy to implant, and also PCO protection, glistening free and minimal incision size with a lesser inflammation. So now the question, which is the best IOL for you, whether hydrophilic or hydrophobic? Again, some people compare on depending upon which IOL really causes a lesser PCO formation. So also you should know also without the disadvantage of multifocal IOL. So coming to the PCO, probably the most common complication of a modern cataract surgery. Basically this postcapsular opacification is a multifactorial. Again, it is depending upon your surgical technique and type of IOL material. So all these factors, there are people say that there is the equatorial cells come to the center that causes PCO. Again, the dissociation of each factor is almost impossible and difficult to differentiate what exactly is the cause for PCO. So coming to the design, you will have optic design, edge profile and haptic material. But what final goal, the lens has to be have a minimization of the decentration, minimization of the dislocation, minimal optical aberration and opacification. So probably a square edge on the posterior surface of the lens provides a barrier for lens epithelial cells to migrating from periphery to the center. So always sharp edge, always better than the round edge with the lesser angulation. So coming to the glistening, I think there is nothing but the fluid filled microvacuoles within the IOL matrix. Normally can be seen as early as even 1 week also, but most of the lens shows glistening, but which is much lesser with the hydrophilic IOL. One of the IOL, I think Acris of IQ showed the highest glistening effect. But as we all know that glistening will not harbor the vision, but definitely there is a gross reduction in the contrast sensitivity. So coming to the refractive index, hydrophobic acrylic always, the study shows that associated with more pseudophakic dysphotopsia than the other material, maybe even related to their higher refractive index and flatter the anterior curvature as well as untreated and also with the truncated intraocular lens edges. But hydrophilic, on contrary, hydrophilic acrylic lenses have more closely mimic biologic tissue due to their higher water content, which ranges between 18 to 34%. That might be the reason for lesser glare and halos and aberrations. Coming to the aspheric IOL, what should be the ideal aspheric IOL? Where the idea of aspheric IOL is to return the eye to the youthful optics. The young eye has got a zero spherical aberration, but as the age progresses, this spherical aberration increases with the functional vision. So let me come to the main talk about my today talk. This is the special lens, there is EMV lens, enhanced monofocal lens from Raynor. It has got a aspheric anterior surface and a unique inner optic design, but the central region they created with the controlled positive spherical aberration to have a extended depth of vision. It has got a blended edge that reduces the longitudinal spherical aberration to maintain the visual acuity and contrast sensitivity under low light condition. And very importantly, these lenses are non-diffractive design that reduces the dysphotopsia. So it is a patented product. They put a positive spherical aberration in the center of the optic. So it does not use the diffractive or light splitting optics. So there is no more dysphotopsia compared to any of the standard multifocal intraocular lens. And it also works together with the natural positive spherical aberration on the cornea that helps for the patient. So this will be like always helpful, especially if you have got a slight tilt also after implantation, or even with the, it takes care about the decentration when compared to the equivalent negative spherical aberration in the different lenses. These are the other properties. Because of this positive spherical aberration, you get the increased range focus up to 1.5 diopter. So high quality of vision, no dysphotopsia. Again, it is called as enhanced monovision. The normally patient will have a continuous range of vision, and also nowadays it even available in toric platform. So coming to the one more feature of this intraocular lens, it is a vacuole free material. So it's a single piece. Normally it can go through the micro incision, but the other very good feature, even it is you can even put a post RD surgery also because of its low silicone oil adherence, excellent EVL biocompatibility, and as we all know that hydrophilic acrylic material with a low inflammatory response. And average offset is almost 0.08 in 3 to 6 months that you have to observe. So the one more advantage with these lenses, this is a sort of a hybrid material with a hydrophilic with a hydrophobic surface with a 360-degree anti-PCO. So that causes like the incidence of PCO is almost less. See, if you compare the different lenses in the market, I think if you can see, I think definitely Ray1 will have a much edges as far as the PCO is concerned, glistening is concerned, even FB value is much higher than any other lens. Refractive index is also lower, that is 1.46, and mean decentration, as I told, 0.08, and of course injecting system is very, very easy to use. It's coming in a fully preloaded system from the factory. So easy to inject also. This is a very small video. I think I'm not showing you the phaco part. Probably we all know that Rayner is the first company to discover, the first intraocular lens has been discovered by Rayner. They have been innovative in year by year, but this is the new lens I used in a very big number. I am very happy with these lenses. This is about the injecting system straight away. Like the whole injecting system is within the saline. They preserve it nicely. There is a small hole there. You have to inject the viscoelastic, then lock it. It go through almost 2 mm incision also, and wound assisted 1.8. And you need not have to do any manipulation, just start injecting the lens straight away into the bag. Viscoelastic removal is very, very important in any of this premium IOL. So coming to the, sir, I am finishing, only one. This is about the defocus curve, is very good. So this is our study. We have done around 300 eyes with EMV and 50 eyes with EMV toric. More than 98% having a comfortable monocular distance vision 6.6, 94% have intermediate, N12 at 40 cm. None of these patients presented with glare, starburst, halos and follow-up in up to 90 days follow-up. None of the patient had any residual toric refraction after usage of toric EMV lenses. And we make non-dominant eye little bit myopic by 0.5 diopter so that patient will have very good near vision. In conclusion, these newer monofocal lenses are marketed as a premium monofocal lenses. They give 20 to 30% intermediate vision compared to the pure extended depth IOL. Best for people with the driving and working with computer with no glare. Enhanced monovision can increase the depth of field, can provide spectacle independence for distance, intermediate vision, and with some patients with near vision also. Ray1 EMV toric is promising in IOL for same without very good rotational stable platform. Once again, I thank Sri Ganesh sir for this opportunity.
Thank you, Dr.